Hello, and welcome to the presentation on maximizing ultra-wide field image quality. My name is Olivia Rainey, and today I will be discussing Optos imaging devices. Optos is recognized as a leading provider of devices to eye care professionals for improved patient care. And this presentation is sponsored by Optos. So on our agenda today is the importance of the periphery, defining what ultra-wide field is. I'll be discussing Optos imaging devices, ProView, and how to use measurements within the OptiMap images, and strategies for improving image quality, such as position, correcting or improving image quality due to artifacts, and talking about imaging techniques. First, I will discuss the importance of the periphery. The importance of the retinal periphery in diabetes has long been recognized, but there are many other diseases that the retinal periphery is extremely important to image in order to monitor any disease progression. The ETDRS7 field was accepted as a standard in 1991 to allow the capture of a larger part of the retina, and that allowed for 30% of the retina to be imaged, roughly 100 degrees. With OptiMap, it allows a 200-degree single capture, and this became available in the early 2000s. Since then, there have been several publications demonstrating the equivalence of OptiMap, and OptiMap has been found to be equivalent for evaluating AMD, glaucoma, uveitis, and retinopathy of prematurity to standard imaging technologies. There has been over 1,000 peer-reviewed PubMed publications using OptiMap, and with this, 136 different disease states visualized on OptiMap as well. The clinical impact of imaging the periphery. OptiMap has revealed that 66% of pathology is outside of the area visualized by traditional small field imaging. That's roughly around 60 degrees. There have been many studies demonstrating the importance of the periphery. For normals, OptiMap has defined the extent of normal retinal vasculature as 977 millimeters squared and choroidal vasculature as 893 millimeters squared. With diabetic retinopathy, OptiMap has found up to 50% more lesions in the periphery, which increases the risk of progression by 5-fold. And with age-related macular degeneration, which many imaging systems focuses on the posterior pole or the macula, OptiMap has found that 97% of patients have peripheral age-related changes. With uveitis and vasculitis, the management is changed 51% of the time by using OptiMap. And with sickle cell disease, 92% had peripheral microvascular abnormalities undetected by the 7 standard fields with fluorescein angiography, and 25% of those abnormalities were missed in exam. Also, OptiMap ICG has found a significantly larger number of vortex vein ampullae than previously reported. It has discovered that the mean number is 8 and the range is from 5 to 13. So that's significantly more than what had been previously reported just by exam and other imaging systems. I want to discuss how to define what ultra-wide field is. The International Wide Field Imaging Study Group of retina specialists with extensive experience in imaging convened in early 2018 to harmonize terms in regards to imaging the retina. So this group came together because they wanted to define what wide field, ultra wide field, and pan retinal imaging really was. Wide field had been being talked about or discussed throughout ophthalmology, especially with new systems emerging on the field. So the following terms should be used to describe retinal images of all types, including fundus photos, OCT, and OCTA. So this group defined wide field as images capturing retinal anatomy beyond the posterior pole, but posterior to the vortex vein ampullae in all four quadrants. It defined that ultra wide field describes images capturing retinal anatomy anterior to the vortex vein ampullae in all four quadrants, and that panretinal is an image which captures the entire retina from aura to aura. And these definitions are used for single image capture, and if you are talking about montaging, you must include that when describing these different definitions. So with that, they ultimately came down to naming that Optos was the only imaging system that could be called ultra wide field imaging through their definition. And here's an example where the Optos image, as you can see, goes beyond the four vortex vein ampullae in all four quadrants, or anterior to. And then here's an example of an ultra wide field fluorescein angiogram with the ETDRS modified standard fields overlaid on top. And as I was discussing before, you can see how much pathology is missed even with montaging or providing those standard fields in all of the quadrants. The peripheral pathology is significant compared to what is being shown with standard imaging. Now on to Optos imaging overview. So Optos provides the only single capture 200 degrees ultra wide field image of the retina. That's roughly 82% of the retina that is captured within that single image. Images can be taken through most cataracts and other vitreous opacities due to SLO technology, which is able to penetrate through these opacities quite easily. It is a non-mydriatic camera. It is able to image through 2 millimeter pupils, which is, as I'm sure all of you know, is quite small when it comes down to pupil size. They're measuring pupil size. So it's able to capture through very small spaces. It is fast, comfortable, and convenient for patients as well. Optos ultra wide field imaging provides multiple imaging modalities. There is the color composite, which is composed of a green and red channel. The green channel, or the red-free image, is a RPE view, or it's imaging the retina itself. This is very helpful when patients have vascular abnormalities, especially when they are on top of the retina. There's also the red channel, which is a choroidal view. This is great for imaging lesions, even finding nevi where maybe it is small or not very pigmented. This channel can help you to distinguish what might be a nevus and what might be an artifact, actually. There's also autofluorescence imaging, which is a green laser, where some imaging systems use a blue This is able to penetrate a little deeper than the blue wavelength. And then there's also fluorescein angiography and indocyanine green angiography as well, or ICG. This is a interweaved feature. It's not simultaneous, but you are capturing these different images a few seconds from one another when imaging with both modalities. OptiMap Plus provides a resolution of 14 microns. There is guided eye steering, so you can move the internal fixation light and you're able to direct the patient to look in a certain direction for montaging purposes. The montages are up to 220 degrees as the retina, which provides 20 degrees more than just the single image. This allows for imaging 97% of the retina, which almost puts OptiMap into the pan-retinal category for imaging, especially when you're using that montaging feature. It has stereo imaging capabilities as well. It has auto-laterality, which means that the system is able to recognize which eye is being imaged for color imaging and for autofluorescence imaging. And this feature is very useful, especially in a high-volume clinic. It recognizes what eye, so then that's one less thing the technician has to worry about. There also is advantages for comparison overlays for monitoring progression and a 3D map, or a 3D wrap, for patient education. So this image on the right here is a image of that 3D wrap. It is fantastic for showing the patient exactly what we are imaging. I'm sure most technicians or photographers have received the question of, what am I looking at here? Is that my eye? And this will educate the patient in where their pathology is located and maybe why they're looking in certain directions. Here's a video of the movement of that 3D wrap. So you can see that when the patient looks up, or if the patient looks to the left, they're able to see the pathology. They're able to see exactly what the physician is looking at. So it definitely is a great educational tool for patients to understand their own pathology. Next, I want to talk about the different device platforms. The Daytona and the Daytona Plus are great for optometry practices. A lot of optometry offices use the OptiMap color and autofluorescence. The difference between the two cameras is one has steering and the other does not. The Monaco is great also for optometry practices, but it is also widely used in general ophthalmology. This is the first integrated OCT and fundus camera that was on the market as well. And then there's the California and then the Silverstone. And these are used in retinal practices a lot of the time because of the FA and FA ICG features. The difference between the two is that the Silverstone now has swept source OCT, which also has navigated OCT. So there's you can take a fundus image and then you can actually find where you might need an OCT scan through, and you can do peripheral OCTs on top of the fundus image. So it's a great tool to recognize where pathology is located in the periphery, and you're able to have another modality in order to see that pathology. I want to talk also about correcting spherical bias. So when a spherical object is represented on a plane, there's unavoidable shape bias that is introduced, which causes inconsistent measurement, especially in the periphery. The ProView software solves this problem by remapping the pixels to their correct location. And the ProView software is within the Aptos Advanced software when you're viewing your images. This allows for enabling accurate measurement across the image, even in the far periphery. So the software actually is able to correct this bias. The corrected images enhance the ability for image registration for disease tracking and intermodality image comparison, such as what you can see on the side here. You can overlay one modality on top of another modality. This is great for physicians trying to see a different way of looking at the retina or specific areas, even great for patient education as well. And here's another example of that using fluorescein angiography overlaid on top of a color image. With measurements, ProView enables accurate measurements even in the retinal periphery. Aptos Advanced software adheres to DICOM Supplement 173, enabling accurate measurement on ultra-wide field images. This accounts for variable pixel distribution across the retinal image. Software must adhere to the DICOM Supplement 173 to provide accurate measurement. JPEG or TIFF images do not retain the necessary information to process measurements. And this is why you must use the software when submitting to different research organizations, because the software holds the DICOM Supplement 173. In the present, Aptos is the only system that has this specific software in order to have that correct measurement, the DICOM Supplement 173. On the side is a drawing to explain how that software is working within the system. And of course, the DICOM test subject validates that accurate measurement across the image. Here's a couple examples of measuring in the periphery. The image on the left, you can see that the patient's looking in the nasal direction, and then the measurement tool is across the lesion, and the same thing for the image on the right. This is a montaged image, lesion again in the nasal position, and just measuring in a different direction. And how do you tell if your images are not ProViewed? If it's not ProViewed, you will see a flat side right here. So you can see on this side how it's a white area here. And then there's also no rounded edge at the bottom or even at the top. So the next slide shows the image on the left, not ProViewed, versus the image on the right that is. So they do look slightly different. The image on the right is a more rounded image, and you can see that the top and the bottom have the rounded edge. And this does not mean that we're losing any information. Again, it's just providing the spherical bias. It's correcting for that spherical bias. So that's how you are able to tell if you are taking the images straight from the software or if you are downloading a JPEG or TIFF file that has not been ProViewed. With this software, you can also measure ischemia. So Aptos Advanced enables accurate measuring of large areas throughout the retina. This includes an auto summation of measured areas. So once the measurement is complete, it will automatically calculate the area that was selected. This feature is being used in multiple pharmaceutical studies to measure disease progression or regression. And this is why it's so important to capture as much surface of the retina as possible without eyelid, without any faceplate interrupting the image. They want to be able to measure as much of the pathology as they can in order to have these studies measure the disease progression or regression. Here's an example of that, and you can see which areas were selected, and then it automatically will give you the measurement here after the selection is complete. And then next I want to talk about improving image quality. So Aptos, as most of you may know, is a little more unconventional when it comes to how the patient is positioned. The patient is faced towards the camera, not facing you. The camera is on a table that is able to go very low to the ground, so it's great for people in wheelchairs. It is great for children, just very easily accessible for a lot of people. The first steps for positioning: you want to have the patient sit straight up. You don't want them to slouch. You want their feet on the floor if possible. The more stable they can be, the better. You want to adjust the table height. There is a canthus mark on the camera, which you'll want to match with the center or the middle of their pupil. Sometimes that can be hard to find, so using the tablet is also helpful, and I'll show a couple pictures of that shortly. You want to guide the patient forward after turning their head slightly to the side. If you're imaging the right eye, you're turning their head slightly towards the right, and then vice versa. Imaging the left eye, the head turned slightly towards the left. It's almost like looking through a keyhole in a door to see who's there. You want to align the patient's eye with the bullseye on the tablet. If the patient can't see the bullseye, then you probably can't see their pupil on the tablet either. So keeping that in mind, if you can't see their pupil, they can't see the bullseye. So directly lining them up exactly with your bullseye first might help you to be a little bit faster when asking the patient to look at that specific target. And then you want to use the controller for fine-tune adjustments. So mostly positioning them manually or physically first, and then using your controller to go up or down, left or right, depending on what direction you need to move them in order to get them aligned. So here is an example of that tablet. So if you can't line them up with the canthus mark on the side of the camera, I use the tablet. So you want this middle horizontal line here, right at the bridge of their nose. So this next image, you can see it's cutting right through that middle of the pupil, right on the bridge of their nose, and you want them looking straight ahead. You don't want them too close. You want to be able to see their face. And then after you line them up with the bridge of their nose on this tablet, then you can turn their head and guide them forward. Just a little trick to help you adjust the table height correctly right off the bat. When the table's too low or too high, that gives a lot of room to struggle with positioning. You want to instruct the patient on what they're going to see. If you don't have the eye positioning instructions, that's extremely useful and is available on the Aptos website. You want to explain what the target's going to look like, what the colors are, but that you are going to be in control of getting them into the right place. A lot of patients might feel like they're not doing a good job if the light's not turning green, but ensuring them that you are there to help and that you will make sure that you get them into the correct position. You always want to tell the patient to open wide before imaging. If you don't tell them to open wide, a lot of the time you are going to capture their eyelid in the image. You want to be loud, but you don't want to yell. When you're monotone, it doesn't show that opening wide is too important. So being a little louder with your voice, but again, not yelling at the patient. You want to watch if their eyelid is lifting before you image. There are times where I ask a patient to open wide and I don't see their eyelid move at all. Sometimes they might not have heard me. Sometimes they aren't they are unable to lift their lid. So just watching their eyelid lift before you click the button. It's always very helpful to know what you are going to get before imaging, especially if that eyelid is in the image. You want to give them a second chance. So if they can't open wide enough the first time, encourage them to try to open just a little bit wider before going to grab their eyelid. So give them a second chance to try to open a little bit wider if you can. And then again, if you can't see their pupil, they can't see the target. So ensuring that you're able to see their pupil and then asking them to look directly at the center. Sometimes turning the chair is helpful so that you know exactly that how much they're turned. You want their head to be straight. You don't want it to be tilted to the side. When turning their head, it's a very straight angle that they're turning. You don't want it to be too angled. That can actually interfere with your image. It can appear to be a tilted image. So turning their chair sometimes will help them understand that they do need to be on the side. And if you're going to touch your patient, always wear gloves. Make sure you're wearing gloves. It makes the patient feel more comfortable, and it should make you feel more comfortable as well. This is a friend of mine, Holly, nice enough to let me hold her eyelid to show how I hold patients' eyelids with the camera. Because they are facing away from you, it is difficult to see exactly where you're grabbing. So understanding that you don't want to poke them in the eye, so you want to maybe bring them away from the camera and then position your fingers and then bring them close again. Trying to find where their eye is when they're that close to the camera might cause you to accidentally poke them in the eye. So you just want to be very careful. Where I hold is at that top of the cheekbone and pulling down for the bottom eyelid. And then for the top, I grab right at the lash line and then pull up so that my finger's more near their eyebrow. That's helpful for me. I use my pointer finger and my middle finger, and then I'm able to fit my hand between the patient and the imaging system so that I can successfully grab their eyelid. There are times where I'm only holding the top lid or I'm only holding the bottom lid. So that's a little bit easier to do. Holding both is always a little bit harder. So a little trick of mine is to tuck my elbow in to cup the patient's ear so that my hand is not pushing on the face pad. When your hand touches the face pad, it might push that face pad in, which blocks some of your peripheral retina when you're imaging that patient. So you want to make sure that you kind of tuck your elbow in and then pull your wrist in as well to cup the patient's ear. It really does make a big difference, especially with the face pad. Sometimes holding eyelids can be difficult. When you pull one eyelid, the other one moves up or down. So here's an example of pulling the top lid alone because I see that this area here, they couldn't open a little bit wide enough here. So I held the top lid and that caused this bottom lid to interfere with my photo. It helped with my top, but it got worse on the bottom lid. Again, your hand can push on the face pad, so that is also something that is very difficult when holding eyelids. And sometimes you can't get a good enough grip. Either a patient has really deep set eyes. I find that not holding their eyelids is more helpful than holding them in some cases. And tearing, if the patient's eyes become very watery, you just don't get that grip. And making sure that they maybe kind of blot their eyes with the tissue, make sure you wipe your gloves off if your gloves are getting a little wet, and then restarting. Just having their eyelids slip out of your fingers is not going to help you. And then if a patient has stiff eyelids or if they're blinking a lot, this also can be very difficult. Making sure that you're asking the patient how you can help them, and just being patient with them. It's not comfortable when you hold their eyelids. So just trying to find which eyelid you need to hold in order to get the best photo, otherwise holding both if that's possible. Sometimes when you are holding a patient's eyelid, you can cause their eye to move, and you can cause these vessels here. You can see that they are becoming a little stretched, and this is because of eye movement. And sometimes you can cause this, or the patient themselves, if they're blinking a lot or if they're just moving their eye a lot, you get these elongated vessels here. But you can see if you take another photo, a lot of the time they can stabilize their eye, and then you're getting a better image the second time. You can see this small dark shadow. That's where I'm holding their eyelid, but it's not blocking enough retina to make me retake the photo. This is pretty good, and so I definitely don't want to interfere with a good quality image, especially if I was getting a lot of eye movement before. The tablet and the controller, they do the same thing when it comes to controls. The controller here has a minus button when the patient's eye is too close to the target. It has a plus button if the patient's too far away and the patient needs to become closer to the device. It has the up arrow, the down arrow, and then side to side if you need to reposition the patient. And then the arrows at the bottom here are for the chin. Either bring the chin rest down if the patient's too high, or bring the chin rest up if the patient's too low. This button on the bottom is for viewing your images. So if you need to see your image in a little bit bigger screen than what's provided, that's available. And then here is the same controls on the tablet. So if you click the alignment button, you receive that up and down, left and right arrow. The support button is the chin rest. So that's actually the plus is able to bring them closer, or the minus bring them farther back. And then when you click on the support, you will receive these two arrows. So you'll receive either bringing the patient up or bringing the patient down. There's also a reset button, which is extremely helpful, especially with peripheral imaging, when you are moving the alignment up and down, left and right to try to track their pupil. This is great to use when you're in between your early and your mid photo, or your mid and your late photo for fluorescein angiography. Resetting your button if you run out of space, if you can't go up any farther with your controller, or in any direction for that matter. And this is very helpful. This is the steering tool up at the top. When you push and hold on the steering tool, it will reveal which way you're going to be turning your target. So for the right eye, if you move the target to the to the left, then they are going to look temporally. If you turn it to the right, they're going to look nasally. So this is just a little hint of which direction you're going to have them look for each eye. So if you're not familiar with the target for each eye, just holding it down, seeing what direction you need them to look in, and then selecting that direction. Next is pupil alignment. This is extremely important in order to capture a good quality image. So the red target means that your patient is too close to the camera. You need to move them farther away. And you can see that the pupil looks really large in the image here. The blue target means that your patient's too far away. And the pupil, it looks much smaller. This is the same patient here. So much smaller pupil, you need to get closer, the patient closer to the imaging device. The green means that you are in the correct position. That might not mean that your bullseye target is exactly in the center. So making sure that you're either going in the center or you are able to make this target turn green, so then you can see if you are in the right position, because these are great guidelines. It works for most of the patients that you're going to be imaging, but there are times where maybe going outside of these parameters are going to help you. There are times where you might not receive that bullseye target. Being patient, maybe moving the patient a little farther back or a little closer, sometimes it will be able to register the target after you move the patient a little bit around. And always try imaging the patient if you can't see the target, and then analyzing your photo that you just took to see if you should move them a little farther back or a little closer. And I will show you different ways to tell if you are too close or too far. This is an example of seeing the patient's eyelid in your tablet photo, in this external image photo, and receiving a image with the eyelid in the photo. So you can see that this second circle here, the bullseye is comprised of 3 circles. There's one closest to the pupil, one surrounding that circle, and then there's one all the way out on the edges. So this middle circle, if that circle is hitting an eyelid, you are most likely going to have an eyelid in your image. You can see in this photo here, the second circle is not hitting any eyelid. So you don't get eyelid in your photo. You get some eyelashes, but you don't get the eyelid. So that's a good way to know if you are going to obtain eyelid in your image even before you take your photo. This is common for when a patient is opening really wide and then their bottom lid comes up. If this bottom part of the circle is hitting that lid, try moving your bullseye up a little bit to avoid that bottom lid, or vice versa. If it's hitting the top, move it down a little bit. Avoiding lid with that second circle is going to avoid a lid in your image. Here are examples of imaging too close. So you get a lot of eyelid. You can even see that there's sclera being imaged. You can see these really large reflections right here and here. This is an indication that you are just too close. You can see that there's a lot of lid in this photo here, which is exposing for the eyelid, which causes the retina to look extremely dark. Sometimes you can see, again, the sclera on the side here. Moving your target back is going to help you with this. So using your minus button right here, you can physically move their head back or away from the face pad. And you can ask the patient to even sit back to reposition not as close to the camera. So sometimes people would just like to push really hard into the camera or the imaging device, and just asking them to sit back and not pushing so hard sometimes will help you to get them a little farther away. And this is an example of the patient being a little too close. I pushed the minus button just a couple of times. I didn't hold it down. It's usually just a couple clicks of the minus button, and then it avoided the bottom eyelid, and then it didn't capture this top eyelid as much. It still captured it slightly, but just not as much as when the patient was a little too close. And these are examples of when a patient's too far away. So you can get these blurred edges sometimes when you're a little too far away. It's, for the most part, it's a pretty good image, but you can just see it, there's just these blurred edges right here. Moving in just a little bit closer can correct the blurred edges. And then you see a dark edge here. This is an IOL. So you can actually see that the patient had surgery and that your camera is imaging that IOL. So pushing in a little bit farther will help you image past the IOL. It's the same thing for this image down here. You can actually see this dark edge. It gets lighter, and then another dark edge. Moving the patient in just a little bit will help you to avoid these IOLs. And then if they're too far back, you might see a dark edge around the image or even the iris itself. So again, pushing the plus button to get them in a little bit closer can help you. Turning their head more to the side, so if it's the right eye, turning their head slightly more to the right, or their left eye, turning their head slightly more to the left. That can help you get them a little bit closer, just close enough in order to turn that target green. You can ask the patient to tuck their chin in towards their chest. This gets their forehead and their eyes a little bit closer to the camera. And you can even move the patient closer to the camera. So maybe their chair is a little bit too far back. Just kind of moving them in a little bit closer can help. Here's an example of that blurring on the edges. You can actually see that the pathology is not as crisp in this image here. And then when getting the patient a little bit closer, it actually helps define this area so much better. So if you ever take an image like this, try moving them in just a little bit closer. You might find that you can get a sharper image by just doing something as simple as getting them a little closer. Sometimes imaging around the parameters is necessary. So if you're unsure if you're in the correct area to image, sometimes just taking a photo to help you understand if you need to move in closer or farther back can help you. Some ways or reasons why to image around the parameters would be an IOL or a cataract, or if they had a small pupil. Using the red target sometimes can help you with improvement of quality. And then the same thing goes for if you're obtaining a lot of eyelid in the photo, or if the patient has really large pupils, or even for peripheral imaging. Sometimes imaging in the blue can provide you a better quality image. And when I say imaging around the parameters, it's just slightly away from that green target. So you don't, when I say a red target, you don't want to go too far away from that green target. It's just very slightly into the red, or then very slightly into the blue. There's a lot of room to move within each target. So it's always just slightly outside of where that normal parameter is supposed to be. A few tricks to bettering or improving your imaging in the periphery is to try imaging when the target is flickering a blue-green color. I find it more helpful to image when it's a little more in the blue compared to the red when imaging in the periphery. I instruct the patient to look in the direction that I moved the target. So telling them to look left. Sometimes it's hard for them to find where that target is, but if you ask them to look in that direction, a lot of the time they can find it quite easily. And then moving the target in the same order if you're imaging 360 degrees. So typically when I'm doing peripheral imaging, I have the patient look up first, then left, right, and then down. And I do that for both eyes so that they know exactly what direction I'm going to move in. And it helps me to be consistent to make sure I'm not missing a certain field. On the right here is an example of the camera exposing for the eyelid. Even though I'm not capturing very much of this eyelid, it causes the entire image to become very dark. So preventing hitting that lid, either holding just the bottom lid down or maybe moving the target away from that bottom lid, can help brighten your image. And you can see it's a pretty significant amount of brightening after the eyelid is out of the way. Different artifacts, you can see here the faceplate, eyelids and eyelashes, edges of IOL, reflections, a blink, and even hair. So all of these are very noticeable in your image. It reduces the quality, and I'll explain a few different ways to help with these. So eyelids and hair, you can see that this is a relaxed eye. The patient did not open wide. And then with this image, the patient did open wide. So you can see quite the difference between the two. There's also consistent hair in both of these images. So asking the patient to either tuck their hair behind their ears or maybe even provide headbands that the patient goes home with. Usually you can find headbands at a dollar store for low cost. So just preventing those little stray hairs from getting into your image. Here's another example where it's just a small amount of eyelid that's in the photo, but asking the patient to open wide and that eyelid disappears. So just a simple instruction to open a little wider can result in a better image. IOL artifacts. So this small crescent on the left side here, this is something that cannot be corrected. If you see this small crescent, it is a reflection from the IOL, and there's really nothing that you can do to correct that other than maybe have the patient look in a different direction. Maybe that will cause this to move in a different spot, so then the physician can analyze that specific area. You can press the patient's head into the red target in order to image past the IOL here. So you can see this type of artifact you are able to correct. So here's another example of the same patient. So you can see the IOL here, you can see the haptics, and then pushing the patient in just a little bit closer helps prevent clipping of the IOL, and then we can see a very clear view of the retina. The face pad in images, sometimes turning the patient's head so their nose is not pushing into that face pad is helpful. It's good to know what side the faceplate is showing. If it's showing on the right side of a right eye, that typically means that it's either your hand pushing against the faceplate. If it's a right eye and it's on the left side, usually that's their nose pushing. So looking around your camera, seeing if the patient's pushing against the faceplate with their nose, or if you are holding their eyelid and you yourself are pushing on that face pad, understanding what's causing that is very important for you to be able to correct that. And here's another example. So this is a left eye, and the face pad is being shown on that left side. So this means that it is typically your hand pushing against the face pad, or maybe their ear, or something that's not their nose. Their nose, it would be on the opposite side. So here's an example of the nose pushing on the face pad. This is a right eye, and the face pad is shown on the left side. So turning the patient's head slightly to the side helps improve the face pad from being in your image. It's important to know that as more time passes, the face pad gets worn down. So here's an example of a new face pad in the front and then an old face pad in the back. You can actually see the bowing of the face pad, whereas this one does not have that. And here's a video of me pushing on the sides. You can see how flexible the back one is compared to the front. So the more flexible the face pad, the more face pad will be in your image. So getting a new face pad periodically is going to help improve the image quality quite a bit, especially if you are consistently seeing a face pad in your images. The corneal reflex typically means that the patient is too close. So either pulling the patient back slightly, maybe pushing the minus button to have the patient go back a little bit, will improve this corneal reflex. It does not mean that you need to turn the lights off. Again, it just means the patient might be a little too close. If you can't get rid of the corneal reflex, you've tried moving them back a little bit and it's still there, just make sure that it's not obstructing pathology. If it is, maybe have the patient look up so that you can image around it. You don't want to block anything that the physician might need to see. The next topic I want to talk about is moving around opacities. You can see that these cortical cataract spokes are moving all around in the image. That's because we're imaging in a different spot on the cornea or on the lens itself every single time we image. So we're imaging through the cornea, through the lens, so we're imaging in different spots of each of those surfaces. So when you move your target, you want to aim your target exactly where the horizontal and the vertical line meet. So that is where you're aiming your target. If you see an opacity on your cornea or your lens, you want to try to image around that. And when you find that window of opportunity, is I call it, then you want to try to be consistent and image in that same spot every single time. So you can actually see that imaging on maybe the left side of the pupil or aiming your intersection on the right side of the pupil might be able to provide a better quality image. So moving your target in different directions, not just in the center of your pupil, may improve the image quality. Sometimes with cataracts, moving in a little towards the red can help move that cataract out of the way. It moves it into a different position. And that's what I did with this example here. I imaged on the green bullseye target for the image on the left, and you can see this opacity blocking the posterior pole. I moved slightly in towards that red target, and it moved it to the side. It's not as dark or prominent, and I can see the posterior pole now. So sometimes taking two images instead of just one can help you see the periphery, but also see the posterior pole or the pathology that you're trying to capture. So another example, sometimes you cannot image, you can't move your target. You've tried, it's not helping, it's not improving this opacity. Going into the red, it's not improving the opacity. Another way to get around an opacity is by having the patient look in another direction. So having the patient look up, I'm able to image around the opacity to see the posterior pole. So I kept both images to show what I did. And sometimes using multiple different ways can help you understand what's going to work best for maybe the next patient that you come across with the same or similar pathology. And then this is the showing the window of opportunity. So when I moved the target in one spot, right in the center, I was getting this extreme haze due to the patient's cataract. I moved slightly to the left, so I'm not directly in the center of the pupil, and I got a much better image. So through this entire FA, I imaged to the left with every photo that I took. And that saved me and the patient a lot of time because I knew exactly where I needed to image for that next photo. So being consistent, remembering where you positioned can really help with improving your speed. So a few different device maintenance issues. The SLO scan mirror line. So I'm sure if you've had a Aptos imaging device for a while, you've seen this line here. When you see these lines, you should request service for the inside of the device to be clean. The device mirrors do get dirty, and this is a specific mirror that's not able to be cleaned by a technician or a photographer. So again, you need to request service if you do start seeing these lines in your image. And then dust spots, so these are a little different. This is on the mirror that we can clean in the office to tell that it is dust or a spot and not pathology. These are two different eyes. So on the left side is the right eye, on the right side is the left eye, and this artifact or this dust spot is in the exact same spot. So this shows me that my mirror needs to be cleaned. And it's helpful to know these things so that you won't image the next patient with that same dust spot. So here's a slide talking about cleaning in between each patient. Of course, we want to always clean anything that the patient touches with alcohol pads. You want to always use air dry techniques. You'd never want to wipe it with alcohol and then wipe it with a tissue or anything that might be causing more dust to get onto your mirror. You never want to use the alcohol pad to clean the inside of the mirror. You're always using the 70% alcohol wipes for the outside, anything that the patient touches. The wipes should always be checked to ensure that they are within their marked expiration date as well. You never want to attempt to wash or immerse the patient contact parts in any cleaning solution or water. And again, you don't want to use lint cloths or tissues or anything that might create more dust. To clean the inside mirror, there is a great video on Aptos.com that shows you and instructs you on how to clean this mirror. You can use the dry cloths, which should be done regularly, especially if there are dust spots on your mirror. The dust cap really does help prevent the dust from getting in there each night. But you want to remove the face pad. You want to make sure you're wearing a glove when you are using the cloth. You fold the cloth in half so that there's two surfaces that are between you and the mirror. And then you want to swipe down in a downward motion. You don't want to push more dust up towards the top. You always want to brush it out of the camera. And again, the video explaining this is extremely helpful. You only want to use the wet pads on spots. So you're never wiping the entire mirror with anything wet. It's always, if there's a fingerprint and you can't get that off with the cloth, then using the wet wipe that's provided sometimes can help with that. And it's only spot cleaning that you would need to use. Now, montaging, wanted to show some examples. All Optos imaging devices have 4-directional LEDs to support eye steering. The images captured from each gaze will then process into a 220-degree montage. You want to make sure that you're using the steering tool for montaging. That is how the system recognizes each field, and then it prompts the system to montage those images. So if you don't use the steering tool, it will not montage. So even if the patient cannot see which direction you are moving your target and you're using verbal direction alone, you still want to move your target. So this is an example of only moving the target in the superior field. And then this is using the target only in the inferior field. And so with color imaging and autofluorescence, you're able to montage. It's not available with fluorescein or ICG. And I wanted to show this image just to show that even if your montages aren't coming out perfect like the prior images that I just shown, they're really nice, no artifacts on the edges. This image, although there are artifacts, if you crop it, it's still capturing everything that we need to see in the image. So the artifacts, even though they are noticeable, it doesn't affect the quality of what you're capturing. So, understanding that every montage isn't going to match up 100% correctly, but you are not losing information by it doing that. And then fluorescein angiography. The benefits of capturing with ultra wide field is that you might not need sweeps. There's faster imaging speed, and it reduces patient fatigue because you're capturing so much more surface area than you would with other devices. Imaging in the periphery during the transit is very beneficial for the physician to see the pathology. There's interweave FA and ICG, which is taken a few seconds in between one another. And then there's auto contrast. So it actually corrects for the exposure automatically if you have that setting capability intact or selected. The timer begins when the first image is taken. So that's very convenient. There's no forgetting to start the timer. If you do accidentally click the button, you want to restart that timer. So there is room for error in that aspect, but you never will not start your timer because your first image is ultimately that timer. So here's just a few examples of just imaging so far out in the periphery. You're able to capture the posterior, the pole, the periphery, and then with ICG as well. Wanted to show an example of manual contrast. So there are times where your ICG might be a little more blown out than it's supposed to be using the automatic contrast feature. So turning the contrast down sometimes can help improve the brightness of your ICG, and then vice versa for fluorescein angiography. Due to cataracts, perhaps, you can get really dark images, or using that contrast tool to turn that contrast up can help you visualize the retina a lot better. So you can see it's quite remarkable how much you can do manually when your automatic features are not working so well. A few tips that I have with angiography. It's useful to use the opposite arm of the transit eye for an injection. So you can see this is an example of transit with the left eye and then using the left arm. It's slightly awkward when it comes to positioning. So having the patient use their opposite arm, so imaging the right eye, use the left arm, and then vice versa. Imaging the left eye, use the right arm. Of course, there are going to be times where you have to image them in a slightly uncomfortable position, But if they can use their opposite arm, it's really helpful for me. Moving the touch screen and hand controller closer to you. So if I am imaging on this side, I'll move my tablet close to the patient's head so that I can see what I'm doing. And then I'll move my controller to the opposite side. So then I have everything available, especially when I'm doing imaging alone. And then using an armrest that is provided on the newer models for the Aptos systems, or having a phlebotomy station if you do have an older model. The armrest that's provided is very helpful. It attaches directly to the machine, the table, and then it can alternate from side to side. So if you need to use the opposite arm, it can move quite easily from each side. And then different challenging imaging situations that you may come across. Patients that have little to no fixation, finding their natural gaze. So taking a picture with where they're looking first, so then you know which way you need to direct them to look. If the patient's looking slightly up, you might need to direct them to look down slightly. And then that goes for any direction. I find that a lot of patients are looking too nasal when they can't see. So having them look more temporally might improve your position when imaging. You could use their seeing eye for fixation if their opposite eye has vision. I tend to use the face plate as an example. So I have them look right at the edge of the face plate with their seeing eye. So if they're looking into the camera with their right eye, I have them look right at the edge with their left eye, and then vice versa. This helps aim them into a position where I'm able to capture more surface of the retina than if I weren't using their other eye. And using verbal directions. So like I said, with finding their natural gaze, asking them to look in a different direction than what they're looking might be able to capture a little bit more centered image. I captured both of these patients who had no central fixation quite easily with verbal direction using their other eye. It's easy to just ask them to look in a certain direction, especially when you're already capturing so much retina in the first place. If the patient has poor corneal quality, you want to use the clearest part of the cornea or the lens, that window of opportunity. You want to try to image outside of the suggested parameters. So sometimes imaging slightly into the red or the blue might improve your image quality, especially if the condition is quite poor. And sometimes just accepting that you're only going to be able to capture some snippets of the retina rather than full pan images, especially when it's this severe. So you can see these are the images from the patient's images that I just shown here. So poor corneal condition, and this is what I was able to obtain. The physician was unable to look inside of the patient's eye very well. He could not see much when he was trying to examine this patient. So he really used these images for his examination, which is extremely helpful for a physician when they're in a frustrating situation, such as not being able to see in the eye. And then different challenging imaging situations that you will probably come across is difficult angiography. You want to always keep encouraging the patient and give positive feedback, even if they're not doing a very good job, making sure that they know that they are trying their hardest and that they are doing well. You want to keep a calm tone. You never want to raise your voice. You never want to give them the idea that you are frustrated with them. You want to ask the patient how you can help them. If they are struggling, make sure that they know you are there for them, and just keep going. Just keep pushing through. You're not going to get perfect images every time, but if you can even capture a small amount that the physician can analyze, that could be helpful. And with imaging children, this is a 3-year-old. You want to build trust. You want to explain to them what's going to happen. You want to have maybe them touch the face pad, not put their arm in because they always want to try to touch the mirror, but just have them touch the face pad on the outside. Possibly image their parent or even yourself to make sure that they understand it's not going to hurt them. Sometimes playing a game or having them watch a video. One time I had them watch a video on their phone and they weren't looking directly central at the target, but I was still able to capture an image that the physician could use and monitor that patient. And then even imaging small areas can be enough. So this is an example of just imaging the temporal area of the retina. This sometimes is enough for the physician to diagnose or treat or whatever the physician needs that image for. A snippet can go a long way. This patient, we could barely put eye drops in her eyes. She was not very compliant, but we were able to obtain these images after building her trust, making sure that she knew it wasn't going to hurt her. We imaged ourselves before imaging her, and then we were able to obtain these images for the physician. The physician, like with the patient who had the poor corneal quality, she used these images for her examination. So this went a very long way. This prevented this patient from going under anesthesia to have her examination. She was able to do that very well with the images that we provided. So in summary, Optos is the only camera able to provide ultra-wide field imaging. Optos imaging has revolutionized ophthalmology with peripheral imaging within a single image. Ultra-wide field could change treatment and management of patients and has been known to do that. And patients could be treated sooner with ultra-wide field peripheral visualization compared to other standard imaging techniques. So thank you very much for your time. Thank you to Optos and to the Ophthalmic Photographer Society for having me speak today.